And everyone can see my notes. That's good. All right. So tobacco and alcohol. Again, the alcohol is probably not the major contributor, but they do act synergistically. So 1 + 1 = 15 in terms of increasing your risk of developing head and neck cancer. Other risk factors, race, gender, age, poor oral hygiene, which we see a lot down here in Georgia, probably in Kentucky a little bit as well. Poorly fitting dentures, rubbing, causing leukoplakia like lesions, environmental hazards, and then blowing smoke in people's faces if that's what you're into. So head and neck cancer, in general, the incidence is going down. So the graph on the upper left is green is for men, blue is for women, and that's the rate over the last 30 plus years of larynx cancer. So you can see it's actually trending down nicely since about 1985, probably when the Just Say No program started, and Nancy Reagan taught us not to smoke cigarettes. And then over here you see oropharyngeal cancer, which right about 1995 to 2000, you see this very sudden increase in the rate of oropharyngeal cancer, and that's because of the HPV virus. If you click back 10, 20, 30 years, you get the hippies, and they're doing all sorts of stuff they probably shouldn't be doing, and that's when this blip starts to show up about 30 years later. Head and neck cancer subsites. We all know these, but oral cavity, oropharynx, and larynx. These two are grouped together in the SEER data. Larynx is its own thing. Hypopharynx, I think, is also grouped in with the pharyngeal numbers. Signs and symptoms, you know, if it hurts and you can't swallow, you're losing weight, you probably got head and neck cancer. Biopsying suspicious lesions, anything you see anything like that, that's something you want to take a biopsy of. Surprising how many family medicine doctors will sit on something like this, or dentists sometimes see something like that and not refer the patient immediately for a biopsy. Neck masses, if the patient's older than 25, most of the time you should sort of already be thinking it's not a branchial cleft cyst. Anything over 40 years old is definitely cancer until proven otherwise, and that's consistent with the Academy's practice guidelines. If it's persisting for more than 2 weeks, they strongly recommend a CT scan, fine needle aspiration, a dedicated exam by someone who knows what they're doing and what they're looking for, which would be you and me. Location of the primary, extent of the primary, cervical nodes that are palpable. These are all things you want to note. Getting the biopsy to get your pathology from the primary is probably preferred to a neck node if possible. But with the unknown primary, obviously that's not where you're not able to do that. And then imaging, CT scan, and probably the chest. So CT neck with contrast is recommended for all head and neck cancer screening or workup. Distant metastases would be most often with the CT chest, and sometimes a PET CT. So we'll talk about PET CTs. MRI would be limited. If the tumor is up against the skull base, there's deep tongue or deep soft tissue involvement, nerve involvement, or it's suspected like the facial nerve or prevertebral fascia. So sometimes in the larynx, you're trying to decide if it's invading into the prevertebral fascia, which would put you into a T4 or unresectable status. So MRI is often helpful there. PET scan, most patients that are going to be getting a chemoradiation protocol are going to be getting a PET scan because the radiation docs like to use it for assessing their treatment response after therapy. And pretty much, even if you're going to start with surgery, if they've got high stage disease, stage 3, stage 4, you're going to be screening for distant metastasis with a PET scan. You could use it for the location of an unknown primary as well. So again, typical disease progression, y'all know this, primary to the cervical lymph nodes to distant metastases. Lung is by far the most common. Liver, skin, bone, brain are kind of the next structures that might be involved with distant mets. Nodal staging has gotten more and more complicated. So it used to be very easy to remember. Now it's gotten to the point where I even will have my NCCN guidelines app up and running during tumor board to refresh my memory every once in a while. So probably not a bad idea to go ahead and download that app if you haven't, so you can have it handy. It's very easy to search the staging systems and be able to do that accurately. So in general, N1 is anything less than 3 centimeters and no extranodal extension. N2 is ipsilateral, 3 to 6, no E&E. Bilateral, or sorry, single ipsilateral node larger than 3 but less than 6 is N1, N2A. N2B is multiple ipsilateral nodes less than 6 centimeters with E&E, negative E&E, and N2C is bilateral. Once you get greater than 6, you're N3, or if you have over E&E, you're N3B, which is a new category in the newer staging system. It's a little bit more complicated for some reason with the pathologic nodes if you've actually done surgery. And I think it's here in this N2 or N3B where the node has to be larger than 3 centimeters and have E&E to be considered N3B once you've done the neck dissection. So not sure the logic there, but that's how it is. It's a lot easier for HPV positive oropharynx cancer. It's just anything, one node less than 6, multiple nodes, all less than 6, or node greater than 6 is kind of your progression. Why are nodes important? Because they are the single most predictive factor in terms of determining survival for most head and neck cancers. So this here is the staging prognostic stage groups for, I believe I chose oral cavity. And you see that if you don't have any nodes, you can be a stage 1 or a stage 2, but even with just one node, less than 3 centimeters, you're automatically a stage 3, which is considered advanced disease. In the oropharynx, HPV positive oropharynx or P16 positive oropharynx, the rules are a little bit different, and the significance of nodal disease is somewhat watered down because that entity is so responsive to radiation therapy. So when you're choosing your treatment, you're gonna go back to these TNM stages and get your overall stage 1 or 2, probably just single modality treatment. Stage 3 or 4, you're going to dual modality at the least. In a lot of circumstances for advanced stage disease, you're probably going to need triple modality therapy. The general strategy is treatment with as few modalities as possible in order to provide best function. You have to consider options for reconstruction if you are considering surgery. And if that's not possible, you may have to shunt them to a non-surgical management plan. Comorbidities and age are certainly going to limit surgery. Sometimes that even prevents a patient from getting treatment at all. And future cancer. So you may have a young person with a larynx cancer for some reason. And although it's small and you would probably standardly radiate that patient, you may want to consider operating on them so that they don't develop a second malignancy, 35 years down the road because they got radiation at 21 years old. Our physical exam for lymph nodes is really pretty bad. There are a lot of papers that you read from, or textbooks from the olden days that say that you should be able to palpate a abnormal lymph node as small as 1 centimeter with high sensitivity. I think that's bupkis, especially in the part of the country that we tend to work in, because the big thick neck, you can't feel almost anything. So Physical exam is not very predictive, but you will have patients coming in with sort of obvious level 2 lymph nodes that they noticed while shaving or putting lotion on or something like that. And those 2 centimeters, 3 centimeters definitely need to be able to feel those. CT MRI is good for detecting lymph nodes that are around a centimeter in greatest dimension. If it's bigger than a centimeter, that's considered abnormal. The one jugular digastric node, the highest node just underneath the jugular, or sorry, just underneath the digastric, you might give that a little bit of an allowance up to about 1.5 centimeters, just because it's sitting there right underneath the tonsil. It's the first node, and it may be just slightly enlarged because of general inflammation in the head and neck area. Central necrosis is bad, round nodes are bad, and the sensitivity for picking up cancer is a lot better with the CT scan. There is, and then on PET CT, anything less than a centimeter is hard to pick up the tumor focus, and 7 millimeters is probably the absolute limit of detection. So you can treat regional lymphatics with neck dissection, or you can radiate it. So when do you want to do a neck dissection? Anytime there's a clinically obvious node that it's associated with a primary that you're going to be doing surgery on, you're going to probably want to do surgery on the neck as well. And if there's a greater than 20 or 30% risk of occult metastasis, which applies to a lot of head and neck cancers, pretty much everything but the ones listed there: early glottic, early lip, early hard palate, and really thin oral cavity tumors. Cystic nodes can throw you off in terms of your workup, but in general, again, like I said before, don't give up on working up a cystic lymph node until you have a cancer diagnosis or you've exhausted all steps. And that would include actually doing a EUA, exam under anesthesia, direct laryngoscopy, looking around, trying to find the primary before you take that patient for an open biopsy. That's part of the clinical practice guidelines by the Academy. FNA is a very good test, high specificity, high sensitivity, especially when combined with ultrasound guidance. It should be used in any solid or any neck mass when physical exam fails to reveal the primary tumor. That's your first step, along with a CT scan, is getting an FNA. We won't review that, but it'll be on the slides. So you can kind of pause here and take a look at the definitions of positive predictive value, negative predictive value, sensitivity, and specificity, because that's good to know for your tests. Neck dissection rationale: it's often diagnostic, where you're trying to determine if there's nodes that have disease in them in the clinically N0 neck, and at the same time therapeutic. So lymph node levels: 1A is sitting right here between the anterior bellies of the digastric, 1B submandibular triangle underneath the mandible but above the digastric. The 2A is above the hyoid in the lateral neck. 2B is behind the spinal accessory nerve. 3 goes down to it depends on if you're talking about the clinical barrier, the surgical borders, or the radiologic borders. So surgically, we always say the omohyoid is our border, and the inferior edge of the cricoid radiologically divides 3 and 4. 5 is behind, and that's the same for 5A and 5B. Although a lot of people will consider the branch of the SCM, or the spinal accessory going to the trapezius, as that kind of easy surgical border between 5A and 5B, and then central neck is 6. I do like to know a little bit about the history of the procedure that I'm talking about. So radical neck dissection was first described by this handsome devil named Jodinsky, who at the time was including the resection of the carotid artery. It was refined by George Kreil in the early 1900s and eliminated the removal of the carotid artery as a necessary step. So I don't know if any of you guys have read the book, The Emperor of All Maladies. It's an excellent book. It's about cancer and its evolving treatment. They do a nice little discussion about William Halsted and his quest to eliminate breast cancer. And it talks a little bit about the word radical. So most people assume that when you're talking about a radical neck dissection, they call it that because it's very extreme. When in reality, the term radical goes back to the Greek root word of root. And Halsted's theory was that he wasn't getting good cure rates on his mastectomies because he wasn't getting to the root of the cancer. And so he would dig deeper and deeper and deeper, taking more and more tissue, including the skin, and then the breast, all the breast tissue, all the axillary tissue, and then the pectoralis muscle, and then actually the rib cage in a lot of cases. And that's what the term radical comes from. So a radical neck dissection, this was coined about the time that Halsted was talking about his radical mastectomy. And so I guess that's why they used the same term. So there's Cryle. Hayes Martin was important in sort of advocating for the radical neck dissection as the method of treatment in the 50s and 60s for anyone with neck disease. And I like this quote: "Any technique that is designed to preserve the spinal accessory nerve should be condemned unequivocally." So he did not like the shoulder. He was not a big fan of people being able to use their arm appropriately. This is just an example of a radical neck dissection, most commonly used now for like a big N3 type node that's clearly invading into the skin and or spinal accessory, this the SCM muscle. And then, you know, in this situation, you're probably going to want to put something over top of the carotid here because it's kind of floating in the breeze. And that's where a nice pec flap would come in. But Boca and Suarez in the late 60s started advocating for preservation of the non-lymphatic structures, including the IJ, the spinal accessory nerve, and the SCM. So they're kind of famous for that. They described that modified radical neck dissection, which is basically levels 1 through 5 with preservation of one or more of these non-lymphatic structures. That's a modified radical neck dissection. So when you say MRND, you're implying levels 1 through 5. Medina then further classified this based on what structure was preserved. And when you preserve all three, then that's typically called a functional neck dissection. And back in the like 90s and early 2000s, they spent a lot of time kind of arguing and discussing about how to classify neck dissections. What's much more common now is that pretty much everyone just does selective neck dissections. So that would be removing only the lymph node groups at the highest risk of containing the metastases, right? So it's different for each primary location, and then preserving all three: the spinal accessory nerve, the IJ, and the sternocleidomastoid muscle. So I guess you could still call it a selective neck dissection if you ended up having to sacrifice one or more of those structures. But if you have to sacrifice all three, you might as well be doing a radical neck because that patient has really bad disease. So there's different other names for these. The supraomohyoid is levels 1 to 3. That would be sort of oral cavity and lip most commonly, floor of mouth, anterior tongue. The lateral neck dissection 2 through 4. That would be for mostly larynx and sometimes hypopharynx. And then central level 6 for thyroid, and posterior lateral, including the suboccipital lymph nodes, retroauricular, sometimes behind the ear, and then levels 2 to 5, and that would be for like posterior scalp, especially something like a melanoma. So Jayton Shaw should be credited, or is most often credited with convincing the world that a selective neck dissection is appropriate, and that's because he was able to map the primary site to lymph node levels that would most likely be harboring disease in a whole bunch of patients. Watchful waiting in an N0 neck. So an N0 neck is someone that has a primary tumor. You have evaluated them with CT neck, and they have no obvious disease. So it doesn't meet any of those criteria that I mentioned earlier. about what a suspicious lymph node should be. And so watchful waiting is one option in that patient, but it can be perilous because there's sort of low salvage rates, especially with a non-compliant patient that goes home and doesn't really come back because their tongue feels great. And then, 6 months later, they present with this big, bulky disease in their neck. So an elective neck dissection, as we talked about earlier, is recommended when the risk of METs, occult METs, is greater than 20 to 30%. So just to review, almost every head and neck cancer, except for early glottic, early lip, early hard palate, thin oral cavity. All right, so, and this just goes to prove that point, or another, as far as the thickness of the oral cavity tumor. So if it's less than 2 millimeters depth, it's about a 7.5% chance of having an occult metastasis. If it's greater than 8 millimeters, it's about a 40% chance. We're looking at 20 to 30%. And 4 millimeters, although it's controversial, some people say 3, some people say 5. I think 4 is a nice little number to land on. But it's important to know what they're talking about when they say tumor thickness. The tumor thickness is always going to be measured from the level of the adjacent normal mucosa to the deepest part of the tumor. So this tumor, even though it's very large compared to this one, you would not measure depth of invasion from here to here. It's only from the normal mucosa down to the deepest part of the tumor. So understanding that definition is important. Again, just talking about what type of neck dissection you might do. If you have an oral cavity cancer, you're going to be doing levels 1A and 1B. The facial nodes underneath the marginal mandibular nerve are a common area of failure because people are not really wanting to go around that nerve, so they leave those nodes behind. Level 2, especially someone who only does 1 or 2, maybe 3 neck dissections a year. So high volume surgeon probably not going to worry about that. But if you're out in the community and you're only doing a few, you need to be very wary of these facial nodes and make sure you're getting them. Levels 2 through 3, plus or minus 4. So skip metastasis to level 4 from the oral cavity is controversial. I think Bob Byers was a big proponent of this idea that could happen. I think most people would not be doing level 4 unless there was obvious disease in level 2. Extended neck dissection. So any neck dissection described above or before can be extended to include lymph node groups or structures that are not routinely removed. Skin, muscles, and nerves are all fair game. The retropharyngeal nodes, paratracheal nodes, upper mediastinal nodes also could be considered part of an extended neck dissection. And then finally, the carotid artery. So retropharyngeal nodes, you've got the medial group, which is immediately behind the midline C1 to C4, and then a bunch of lateral nodes lateral to that. If they're enlarged, you might hear someone call one single node back there enlarged, being called a node of Rouvier. And when you do a retropharyngeal lymph node dissection, you're going to be targeting all these lateral nodes. Drainages from the nasopharynx, the tonsillar fossa, hypopharyngeal walls. And it can be seen in advanced tonsil and oropharyngeal cancers as well as hypopharynx. So paratracheal, a lot more common in subglottic tumors. So if you're doing a laryngectomy for a subglottic tumor, you probably need to think about doing extended neck dissection with some paratracheal nodes in level 6 included. Carotid artery. If you find that your carotid artery is encased with binodal disease, you might need to be considering taking that if you're going to treat that patient surgically. You definitely want to assess cerebral perfusion preoperatively. There's good discussion of this in the Bailey's textbook in terms of what tests you should use and the pluses and minuses of all these things. So I won't go into too much detail there, but you want to assess cerebral blood flow prior to surgery so you don't just automatically stroke that patient out and kill them trying to do surgery on them. And then you might need to do sort of an intraoperative evaluation. Sometimes you think you're going to be able to peel something off and you you simply can't do it. And that's when you're going to want to call in your vascular colleagues to assess whether they can do some sort of reconstruction or shunt to help you out intraoperatively. Post-operatively, you got, even with a good screening pre-op, you still have about a 25% risk of a stroke in your patient that you resect the carotid artery without a reconstruction. I guess contraindication to neck dissection, clear carotid involvement that you're not going to be able to get the patient through any sort of resection and reconstruction. You're not going to do that surgery. And then involvement of the skull base, prevertebral fascia is a common one, and vertebral bones, especially if it's surrounding the vertebral artery, and then the brachial plexus, because you don't want to paralyze someone's arm to get their cancer out. Adjuvant post-operative treatment, XRT is reserved for high risk, or very common in high risk patients. Extracapsular extension, perineural invasion, positive margins, and multiple nodes. This should all be kind of on the tip of your tongue when someone asks you what are some of the indications for adding radiation to your patient after surgical management. Close margins is a bit of a question. A close margin would be considered anything less than 5 millimeters. So there are some studies that show that people with close, quote unquote, close margins actually do worse than people with positive margins. And I guess the supposition there is that those close margins are probably actually positive somewhere. And because they're often not treated with radiation, because the operating surgeon says, kind of breathes a sigh of relief and says, oh, I was close, but at least I got it. They end up recurring due to that positive margin. So a close margin is something to strongly consider whether or not you're going to give radiation for, even though it doesn't strictly meet the indication of a positive margin. And they usually do sort of a 50, 60 degree, a 60 gray treatment to that nodal echelon or that side of the neck, and boost in the areas of extracapsular extension. Chemo is indicated for two things: concurrent chemo, extracapsular extension, and a positive margin. And those have been shown to improve local regional control and disease-free survival, but not necessarily improve overall survival. So it's kind of a local phenomenon that you're most worried about controlling in that setting. So I guess that would imply, if it's local regional control and disease-free survival, it's probably distant mets that are going to be developing, that are going to be end up ending those patients' lives. Controversies, the single neck node. A lot of people would consider surgery adequate for treatment of a single lymph node. But there are a lot of people that also believe that there's a high recurrence rate if you don't give that patient XRT. So you can argue about that in your tumor board. But most cases, you're probably not going to give that patient radiation for just one node positive. Planned neck dissection. I guess this would be if you are concerned that due to the bulkiness of the disease, you are not going to get a complete response for chemoradiation protocols. I really think that most people would not do a quote unquote planned stage neck dissection, but it is very common to do a salvage neck dissection after chemo XRT. And this is kind of always been an evolving phenomenon. So from a historical perspective, back 30 years ago, once someone got chemo XRT, they'd come to the clinic, and if they had any palpable disease in their neck a month after radiation, you would do a neck dissection. What they found was they were doing a lot of negative neck dissection. So they were finding nodes, but no viable tumor in those nodes. So then they said, oh, maybe we'll be able to assess this better with a CT scan. So they started doing CT scans at 1 month and looking at those nodes to see if they're necrotic centers or if they looked like they were necrotic in nature and maybe resolving, but they would still end up doing a whole bunch of negative neck dissections, no viable tumors. So then PET CT thankfully rolled around. Initially, they were using it at 8 weeks, again with a lot of false positives for suspected residual disease. And so right now we've settled at 12 weeks, but I bet a lot of you guys have been to tumor boards where someone's ordered the PET scan a little bit early. Maybe they ended up getting an 8-week scan, or it's a 12-week post-surgery followed by adjuvant chemo radiation scan, and it's 12 weeks, but there's a little bit of residual activity. And it seems like more and more in the tumor board, we're kind of hedging on those and saying, hey, why don't we repeat that PET scan in 2 or 3 months and see if there's any activity left. So we're not doing a lot of salvage neck dissections for mildly suspicious PET scans at 12 weeks. Whereas anything that's red hot, that should be a clear indication for taking that patient for a salvage neck. And then there's pre-treatment neck dissections. So really bulky nodal disease. Again, it's controversial, and it would be up to sort of the climate of your tumor board to decide how you manage those. Some radiation doctors really prefer to have the first crack at this. At our tumor board, we're most successful in advocating for taking that N3 disease out to basically cyto-reduce the tumor and increase the chances that the chemoradiation is going to work. So we'll move into some anatomy here. So the layers of the neck, always a good question to have in mind for when you're stuck operating and you've got a med student assisting you and you don't know what to pimp them about. The investing layers of the deep or the layers of the deep cervical fascia is always a good thing to ask them about. Most of you guys will never actually see any of these incisions. So these are all the incisions that people have advocated down through the years for doing various types of neck dissections. At our institution, and I bet most of the places you guys work, your head and neck cancer surgeons are probably doing almost everything through a simple mid-neck horizontal utility incision that probably measures about 6 to 8 centimeters. And you can do everything you need to do through that one incision without worrying about all these limbs and trifurcations. So these are for historical interest. You should review them in the surgical atlas so you know some of the names, but not necessarily something that we're going to use very often. Vascular supply to the skin comes to the facial artery anteriorly, occipital artery, perforators, suprascapular artery, and transverse cervical artery supply most of the blood to the neck. Platysma, the wide fan muscle. I used to think this was a phantom, that the attending and the resident were playing a joke on me as a med student saying, do you see the platysma there? Because I almost never was able to see it. And I thought it was a figment of their imagination until I had done about maybe like 5 or 6 neck dissections on my own in residency. So it becomes much more obvious down the road. It's also, so it's innervated by the cervical branch of the facial nerve, and it depresses the corner of the mouth. So I would say a lot of the situations where you end up with a post-op parotid patient that has lower quote unquote marginal nerve weakness. It's actually not the marginal mandibular that you've compromised. It's probably the cervical branch going to the platysma that pulls on that lower corner, or you haven't even damaged the cervical branch. You're just divided the very far lateral fibers of the platysma, which are kind of feeding up into this tissue just lateral to the mouth and pulling that corner down. So this is my personal little theory there. SCM, innervated by the cranial nerve 11, and common sort of pimp question in the operating room, blood supply is actually from 3 different sources up high. It's the occipital or directly from the external carotid. Superior thyroid takes care of the middle part of the muscle, and transverse cervical supplies most of the blood supply to the inferior part. So Depending on which direction, if you're going to use a SCM flap, depending on which direction you're going to base that flap, top or bottom, that blood supply is going to be coming from a different artery, and that's kind of a common question people might ask in the OR. Omohyoid is one of the quote-unquote residence friends that protects the internal jugular vein, or the carotid sheath, more specifically there, over both the carotid and the IJ. It sits in the lower neck. It's got two heads. I like to ask med students about what the OMO is. And most of them don't know that it's actually attaching to the shoulder. And OMO, I guess, is the Latin root for shoulder, like ombro in Spanish. All right, digastric muscle, the other residence friend. It's a sling-like muscle up higher in the neck as well. Anything important in the neck is going to be deep to this digastric. There may be some small blood vessels that course over the top of it, like the common facial, but the vast majority of the important vascular and neurovascular structures will be underneath this muscle. It's got actually two nerve supplies, so that's a commonly sort of asked about fact. Anteriorly, the anterior belly is supplied by cranial nerve 5 as a muscle of mastication, and the posterior belly is supplied by cranial nerve 7 as somehow as a muscle of facial expression, I guess. Spinal accessory nerve, fun fact, starts in the spine, as well as there's the cranial nerve rootlets. It goes through two foramen, into the foramen magnum and then out of the jugular foramen, with cranial nerve 9, 10, and the jugular vein. Relationship of the spinal accessory nerve to the IJ. This is out of a textbook. Again, when you identified in the surgery, you've identified the spinal accessory nerve, you can actually trace that nerve back in order to find this lateral border of the internal jugular vein. And most of the time you're going to be tracing that nerve, it's going to course anterior to the jugular vein. So that's important to remember. You will be on top of this nerve, so you should technically be protected from getting into the jug in most cases. But you can have in about 30% the nerve going behind. So if you're just sort of willy-nilly cutting through this tissue, elevating tissue over the nerve and blasting through it, you might end up into the jug. And then I didn't believe that this actually existed for a long time. I thought it was just kind of a corny thing to say that 3% of them went through the vein. But I have seen two times. One, it actually went through the vein just like this, and there was like a little hole in the vein. And the other time, the vein was sort of bifurcated right here. Great auricular nerve. It's just posterior to the external jugular vein. Common misconception is that this point where the great auricular nerve is coming out from behind this sternocleidomastoid muscle is Erb's point. It's not. It has nothing to do with Erb's point. Erb's point is a surface landmark that Erb, who is a neurologist, not a surgeon, was used to describe a location where he could reliably stimulate the brachial plexus. So it has nothing to do with the great auricular nerve or any of these nerves, sensory nerves that are coming around the backside of the sternocleidomastoid muscle. So don't refer to this as Erb's point. And the great auricular nerve, again, courses up here and provides sensation to the skin anterior to the ear, the lobule, lower ear, and some of the posterior ear skin. Marginal mandibular nerve, a lot of consternation about this guy. It really should be preserved in neck dissection, supraomohyoid neck dissections, unless it's involved. I think the rate at which this comes down below the margin of the mandible and onto the submandibular gland is probably overstated. You might find little twigs and branches doing that, and they probably are contributing to some of the lower lip movement, but I'm not convinced that those are the main branches that are responsible for that in the vast majority of cases. But it does behoove you to find those guys as best you can, elevate them in the fascia, up and over the mandible when you're taking the facial artery vein. You can transpose that nerve, but you do, like I said, need to be very careful to get these facial lymph nodes that are residing around the facial artery and vein to avoid a recurrence. Phrenic nerve, definitely want to be careful about this guy down lower in the neck. It's going to actually be coursing sort of lateral to medial over the anterior scalene muscle here in the deep neck. And you'll know you're at that level when you start seeing the transverse cervical artery, and the vein over top of that. And it's going to be covered by prevertebral fascia. So you should see, or actually feel, most often, if you have your, if the assistant's kind of got their hand, or a med student's got their hand resting on the patient's chest, they'll feel that diaphragm bump anytime you're bowing near the phrenic. And that's your warning to kind of lay off that area. So level 1 neck dissection, again, you're going to be taking level 1A, which is some sort of midline and doesn't have a laterality, so you just call that level 1A. And then level 1B, everything lateral to the digastric, superficial to the mylohyoid here, detached from the underside of the mandible. You dig up underneath the mylohyoid to detach the submandibular gland from its duct and from the lingual nerve. And then you keep working back and you detach that gland from ligate the facial artery here just above the digastric and here at the mandible to complete that neck dissection. Now, if you're doing a flap, your flap surgeon is going to thank you if you preserve a decent stump of that facial artery coming from behind the digastric. So you may take it at the mandible and then trace it back through the gland to give them something to actually work with. I love some of these pictures. Just real quickly, the steps of the operation. This is common facial vein, which they've ligated as they divided the fascia of the submandibular gland, inferior gland, to elevate it up. You can preserve that if you want. This is the external jugular vein. They must hate it because they've ligated it twice. A lot of times we just sort of retract that up and out of the way, off of the muscle, let it go into the parotid without dividing it, so that it can also be possibly used for a free flap. Here they're unwrapping the fascia off of the sternocleidomastoid muscle to start developing that fascial envelope. Here they've unwrapped the SCM. They've identified the spinal accessory nerve. They're lifting it up, taking level 2B out from the floor of the neck and passing it underneath the spinal accessory. Here's another picture of that. So they've freed up level 2B and brought it down. And now dividing posteriorly into the deep part of the neck down to the floor. And you see these little red lines. These are the cervical rootlets. You're going to stay on top of those. You don't need to divide those in most selective neck dissections. But that's your sort of indication that you've reached the floor of the neck and you want to start working your way forward, elevating this lymph node packet off of the underlying nerve rootlets and the fascia that are associated with them. Once you get here, you're going to see the first thing you could encounter is actually the carotid artery. Although it's medial to the jugular vein, the jug is up here. It's usually sort of elevated with your lymph node packet. So if you're right along the deep cervical fascia over these nerve rootlets, it will take you directly to the carotid sheath. So you need to remember that, because deep cervical fascia, it forms one of the layers of the carotid sheath. So if you're on it, it's going to take you right there. Don't get into the carotid. Be looking out for it. And then when you see it, you're going to jump up and you're going to start dissecting that tissue off of the backside of the jugular vein. You're going to knife everything cleanly off of the jugular vein here, divide any branches that are necessary to free the specimen, and take the specimen out. And this is, again, just a picture of what it should look like when everything is done. Post-op complications, chyle leaks, I hate them. Anytime you're down in left level 4, it's high likelihood that you're going to get a chyle leak. It's best if you can identify that intraoperatively and fix it before you get out of there. Pretty common algorithm for what to do if you don't recognize it and it develops afterwards. And you can read about all these different complications in a textbook. This is a nice little video I'll jump through some of it. It runs, let me go back, see if I can get it to run. Come on. It runs about 5 minutes. And it's not going to work in this. It's not going to work because we're in this presenter mode. So that's okay. If you want the video, just let me know. Send me an email. M Groves, sorry, I don't have it on here. M Groves, Grov as in Victor, ES at augusta.edu, and I'll send you the video. So with that, I will open up the discussion or the floor to any questions that anyone might have.
Hey, Mike, I don't know if you have your chat up, but there was a question earlier from Dr. Liebman.
Okay.
Do you have at the bottom?
Let me end this show. My computer is doing funny things now, and I can't. It's splitting my screens, and I can't go back to this. There we go. Hold on. There we go. Okay, sorry. Let me open the chat. So how about if, okay.
That was when you were talking about doing upfront dissection for N3 disease.
Whether or not, so you're asking whether or not yeah, so if you have N3 disease, like if you got a 6 centimeter lymph node, it's almost by definition going to have extranodal extension, right? So that's the reason that we tend to want to do the upfront neck dissection, because we have this really aggressive, gross, giant tumor that's got E&E everywhere, and the likelihood that you're just going to be able to zap that with radiation and cure it is really, really low. So we would almost rather deal with that big, ugly node with taking out all the structures that it's invading, and do that in a non-radiated field than have to do a similarly painful operation, but add on top of that radiation. Now, if there's carotid encasement by that node, then I think you still follow the rule of you're almost never going to be doing that operation to remove the node that's encasing the carotid, but it would be something to be discussed at the tumor board. So Jeff Singh says, if you have a preauricular cutaneous squamous cell cancer that you're doing a parotid neck on and an N0 neck, do you routinely remove the entire parotid gland, or does a superficial parotidectomy suffice? So I think I would say the treatment, the aggressiveness of management of the parotid for cutaneous mets to the parotid, or actually any parotid malignancy, is sort of evolving, where probably 15 years ago, and even when I started this job about 10 years ago, I had a young lady with a superficial lobe, I think it was a cynic cell carcinoma, and one of the more senior guys sort of challenged me on whether or not I was going to do a total parotid for that, and I said I was actually only planning on a superficial, and he was a little bit miffed by that. But I would say a superficial is sufficient if you've got no evidence of deep lobe metastases. There are probably only about 3 or 4 lymph nodes deep to the nerve in most patients, most people. It would be unlikely that would be participating in the drainage pathway of any sort of skin malignancy. It's not impossible, but I think in an N0 situation where you don't have anything obvious on a scan, superficial parotidectomy and probably like a 2-3 neck is going to be sufficient in that setting. Any other questions?
Yeah. I had 2 more questions.
Sure.
Do you ever go backwards? Do you ever skeletonize the jug and then work medial to lateral?
Right. So good question. I guess the answer to that is that you have to do what my mentor, one of my favorite surgeons that I worked with at Baylor, Bob Park, would say. You have to let the wound talk to you. And yeah, you might go backwards if there's some reason that technically going in the standard sort of series of steps is either impossible or it's giving you fits in some way, and you need to sort of reassess. So I don't make it standard practice. I don't commonly go from jug and work back, because I think that it's nice to know that level of the deep neck by finding your cervical nerve rootlets laterally. And it's a safe way to approach the carotid sheath because you know it's where you're going to find it reliably. But if you've got a big, let's say you got a big node that's involving the SCM, it's stuck down to the floor of the neck, and you're not really sure how you're going to take it, then I think coming from medial and working laterally is perfectly acceptable. So letting the wound talk to you is sort of one of those high-level surgical skills that develops over time and with experience, because you learn tricks about how to get yourself out of trouble. And I think that when you guys are doing neck dissections as residents, even as chief residents, and you've got the faculty there, and they're being dumb help, right? So they're just doing what you're telling them to do, but they're still doing a good job of doing it. That's called dumb help. You're going to think that a neck dissection is like super easy. Like it just makes sense. You know the steps, everything's going really smoothly. You take that dumb help away and you put someone in there who's no help, who doesn't know the steps of the operation, doesn't know anything about what's going on. Sometimes retracts okay, sometimes doesn't. And suddenly a neck dissection becomes very complicated. Also, when you have disease. So an N0 neck is pretty straightforward almost every time. Some little anatomical variants that you need to be looking out for, but for the most part, it's pretty standard. But when you start throwing active disease in there, bulky disease, you really have to start evaluating strategies for managing that and getting around it, knowing where your structures, the next structure that you're looking for is, and finding strategies to identify it without injuring it by sort of thinking outside the box or making moves that you wouldn't typically make in a standard neck dissection like the Myers textbook describes.
I guess lastly, do you do anything special to level 4 to avoid intraopically as far as your dissection?
So yeah, so that again, the dissection of level 4, I think the technique is sort of evolved. We sort of do like minimal cautery down there. We sort of use the cautery to sort of loosen the tissue, and then do more of a sort of a sweeping of the nodal contents and the fat up using a Raytech. And I think that gives you a little bit more of an opportunity to identify those fragile little vessels. If you're pulling something up off of a little chyle vessel, you might be able to see it before you injure it, and then ligate that area specifically. In residency, I was trained to clamp and tie everything down there. So that's another strategy. You start at the lateral jug, you dissect up underneath, being careful not to accidentally hook something like the phrenic or the transverse cervical. You hook underneath, lift everything up, clamp it, and cut above that clamp, and then tie, suture ligate all that fat underneath your clamp. So I think both are good methods to avoid injury of a chyle vessel down there. But if sometimes you're chasing after a big node that's basically just integrated in all those little fragile vessels, and you're going to end up with a chyle leak anyway. So it's not uncommon to be dealing with something down there and just throwing a whole bunch of silk stitches down there to try to put some pressure on the area. Sometimes I'll divide the omohyoid and stuff it down there. Sometimes I'll divide if I've got a bad one, I'll divide the sternal head of the SCM and sort of wrap it around the backside, and wrap it around forward and and throw it in that space where the chyle leak is, to try to get some inflammation going in that area to stop it. So, all right, I think we're out of time. Thanks guys for tuning in. I hope it was moderately informative. And like I said, if you have any questions, let me know. mgroves@augusta.edu. Thanks.
Thank you, Mike. Really appreciate it.